بسم الله الرحمن الرحيم. أنا اسمي الدكتور محمد السيد رشيد، أستاذ الجراحة العامة جهاز الهضمي. الموضوع النهاردة هنتكلم على Ventral Hernia. ده النص الثاني من الهرنيا، لأن النص الأولاني هنتكلم دلوقتي هنقول إيه اللي موجود. Ventral Hernia, any protrusion through the abdominal wall with exception of hernia through inguinofemoral region is defined as ventral hernia. Ventral hernia includes incisional hernia 80%, umbilical hernia, epigastric hernia, and para-umbilical hernia or Spigelian hernia. As you see here, this is the hernia, this is the site of the neck of the sac, and this is the abdominal wall here, and this is the contents, intestinal contents into the sac. The ventral hernia can be either reducible or irreducible. Reducible means that you can push it backwards, and then when the patient coughs, it comes. Irreducible, you cannot push it back because of adhesion. Obstructed, other presentation. Strangulation means that there is interference with the blood supply, arterial and venous, with the net result that the loop or the contents of the hernia will be strangulated. Strangulated means it loses its blood supply, becomes blackish, and if you try to strengthen or to increase the oxygen, the color does not change. It may be single or it may be multiple small defects like Swiss cheese hernia. Causes of the ventral hernia may be congenital defect, obesity, smoking, and chronic cough. The management of ventral hernia includes relevant investigations, routine investigation, complete blood picture, blood urea, urine examination to evaluate the condition of the patient, and then open mesh repair. Open mesh repair means you will use mesh. This mesh may be inlay or onlay or sublay. Sometimes you can use the mesh in retrorectus, which is called underlay. Laparoscopic mesh can be used. Laparoscopic mesh replacement can be used by underlay directly in front of the contents using dual mesh or 4-layered mesh. Preoperative preparation includes proper skin hygiene. Of course, if the skin is inflamed, this is serious because it will lead to infection of the hernia, repair, and not only that, recurrence and evisceration of the intestine. Number 2, respiratory care. If the patient has any problem as regards the respiration, chronic bronchitis, bronchial asthma, this is also serious because it will lead to wound dehiscence and also complications of recurrence. Control of obesity, and this may be done by the usual drugs or exercise. More exercise. If the patient is obese, then we have to use gradual exercise, not severe exercise. Antibiotics. Antibiotics is important because liability of infection of the hernia is found, and this may lead to dehiscence and recurrence. If you look for the ventral hernia, this is the position of the abdominal wall, and this is the site of the linea alba and the intersections of the muscles here, and this is the site of position of the surgical mesh, either onlay, this is onlay, or inlay or sublay. Incisional hernia. This incisional hernia constitutes about 90% of ventral hernia. Incisional hernia occurs through a weak abdominal scar, which is a scar of previous surgery. It is common in old age and obese individuals. That's why here we repeat the word obese, because obese means that fat replacement instead of muscle, and this fat is usually leading to weakness of the abdominal muscles, our abdominal wall. It occurs in 10% of abdominal surgeries. 70% occurs in the first 5 years, and 30% occurs in 5 to 10 years. Additional history has to be collected as regards diabetes, hypertension, other consecutive diseases with the patient, which may lead to liability for infection. Incisional hernia predisposing factors are vertical scar, also midline scar, lower abdominal scar, 2. Scar of major surgeries, emergency surgery. Emergency surgery means that you open the abdomen in a bad atmosphere or bad condition. Liability for pus is present, and this is a need for infection and for wound adhesions. Faulty technique of closure. This is another factor. So vertical scar, midline scar, lower abdominal scar, scar of major surgery, emergency surgery, faulty technique of closure, poor nutritional status. Old man, he is not taking good diet. This means that the tissues will not be repaired in a good condition because of the poor nutritional status. Coughing as well as malignancy. This will lower the immune response of the body. Causes which increase the intra-abdominal pressure, like stricture urethra, like anal conditions, chronic anal fissure, which leads to straining with increased intra-abdominal pressure. What is the clinical picture of incisional hernia? There is swelling, there is pain, there is impulse on coughing, gurgling sound, often bowel peristalsis may be visible, and sometimes the intestine or the bowel may be under the skin and you can see the peristaltic movement. Eventually features of irreducibility, obstruction, and strangulation. Preoperative preparation includes that you have to ask for the other condition which diminish the immune response of the patient, immunity, the defense mechanism, the nutritional status, old man with diabetes, with hypertension. These factors will lead to problematic condition after repair. Treatment strategy for incisional hernia. Number one, mesh repair of the incisional hernia. Why mesh? Because usually the effect is big, so you can't do immediate closure. Immediate closure will lead to compartmental pressure on the abdomen with raising and fixed diaphragm, and the patient may die from CO2 retention in peace. Laparoscopic mesh repair can be used also. Cattle's operation, double breasting of the rectus sheath, keel operation, and Nuttall's operation. Here is Cattle's operation, which includes 5 layers. First layer is the peritoneum. We close the peritoneum first. After we open the sac, we do lysis of the contents, we reduce the intestine, and then we have the free edge of the peritoneum. This is the first layer to be closed, the peritoneum. Second is the edge of the sac itself. second layer. Third layer is the posterior aponeurosis layer. We close the posterior aponeurosis. Fourth layer is the muscle. Fifth layer is the anterior aponeurosis. This is Kettle's operation. 5-layer repair. Incisional hernia complications are wound infection, seroma formation, paralytic ileus, abdominal compartment syndrome in large hernias. And this means that if you have large hernia, don't do repair immediately and let the patient in the surgical ward. No, he has to be put on ventilator so as to capacitate the contents until the patient can return his normal vitality and normal respiration. No position as regards the patient after operation in large hernias to be put in the ward. No, he has to be put on the ventilator so as to coact the diaphragm, which is static after you do compression and cannot move properly. And the oxygenation is bad and CO2 retention is rising, and the patient may die in peace. Wound sinus, when you take a stitch in the intestine, this may lead to wound sinus, either small or large. Enterocutaneous fistula, also either large or small. Infection of the mesh and recurrence. Usually the type of mesh is important. Usually the Prolene mesh is good than the Verzeline, and recurrence is also occurs. If this complication is found, recurrence of the hernia will occur. So this is the umbilical hernia, anatomy of the umbilical region. Here is the umbilical cord with the arterial and venous supply, and also this is the umbilical artery usually carries venous blood, and the umbilical vein carries oxygenated blood. The umbilical hernia, and when you look for that, the site of the umbilical hernia is in the umbilical region. Umbilical region is bounded by two vertical lines, started from the mid-inguinal point, right and left, vertically. Then you have 9 compartments of the abdomen. The left hypochondrium, as well the right, and in the middle is the epigastric, left lumbar with the right as well as umbilical region, and left iliac with right as well as hypogastric region. Umbilical hernia can be congenital in newborn and infants, and usually common in males. This umbilical hernia, which is congenital, it is called exomphalus, maybe exomphalus minor, I mean small type, or exomphalus major. Exomphalus minor means that you can do ligation of the stump with the cord and you close it, no problem. The umbilical hernia, which is exomphalus large, means that there is extrophy of the sometimes the urinary bladder with the large contents of the intestinal contents within the hernia. This means that you have to correct it by staging, because the pelvis of the kid is small, no abdominal cavity, and the contents all over is outside, and this may be ruptured during labor. While the kid is in labor, it may rupture and the intestine come out. What you are going to do? You have to do staging. First of all, you can use a piece of mesh, big mesh, to cover it, and with dressing until you get the pelvis developed by air inflation within the sac. till the pelvis develop, then you can introduce the intestine and use the mesh and close it. This may got hernia, and you have to repair it after the child becomes big and the abdominal cavity large, so that it can capacitate or use the intestine inside. This is a congenital, exomphalus minor or exomphalus major. Second is the acquired. Acquired usually occurs in adults and common in females. Why? Because of the repeated pregnancy, weak abdominal wall, and because of the frequency of increased intra-abdominal pressure. So this is the site of the umbilicus, and this is the site of incision. If we use incision for repairing of congenital umbilical hernia, usually we repair it if the size of it is more than or around 2 centimeters, around 1 inch. Then we use semilunar incision, infra-umbilical semilunar incision. We open the skin and then we reach to the sac. We look for the sac if there is any adhesion. We do lysis and re-put the intestine inside. And then we close the defect. Of course, if the sac is redundant, we excise a part of it to repair, to narrow the neck of the sac. Indication of surgery, as I told you, if it persists even after the age of 2 years. Usually before 2 years we can use thrusts or we can use appliances to let the tissues develop and close the rent. If it is 2 centimeters or more, then you have to do repair. Acquired or adult hernia, umbilical hernia, has to be prepared. Umbilical hernia, different categories. We have primary closure of the defect. This is usually in the small congenital hernia. You can use May's repair, and I will told you about May's repair, sublay mesh repair, umbilectomy, open dual PTFE and polypropylene mesh placement, laparoscopic umbilical hernia repair. PTFE type of mesh. This is May's repair. If you look for May's repair, we do transverse incision. This transverse incision let us with 2 flaps, upper and lower. We use the edge of the lower flap with the faraway sutures of the upper flap, matrix. So we come here to the lower edge and then we return again to faraway sutures. This is called matrix sutures. Matrix sutures. Here you can identify by this picture. The idea of this matrix suture is that you strengthen. It is a poneurotic suture repair. So you have to use non-absorbable sutures, because if you use absorbable sutures, it will disrupt within 2 to 3 months and the recurrence will occur. Paraumbilical hernia may be supra or infra-umbilical type. It occurs commonly in adults. It is a protrusion of herniation or herniation through linea alba, just above or below the umbilicus. Treatment is always surgery. May's repair can be used as well. Epigastric hernia, fatty hernia, it is called fatty hernia of the linea alba. What is epigastric hernia? It occurs in the region of the epigastrium, which is limited from the umbilicus to the xiphisternum. It is 10% common. It is common in males. 20% of epigastric hernias are multiple, what's called Swiss cheese-like. Why? Because this is the line of the linea alba, small defects may occur. It is not one defect, more than one defect. That's why it is called Swiss cheese. And also, this is important because if you are going to repair the epigastric hernia, don't use transverse incision, because transverse incision will repair one type of hernia, but usually we use vertical incision, because through the vertical we can repair all the sackless hernia. It is sackless hernia, hernia without a sac. Often it is asymptomatic, but sometimes the patient may get heartburn. That's why you have to look for peptic ulcer disease. You do endoscopy for gastroscopy to visualize the stomach if there is any associated ulcer with. Spigelian hernia, it is lateral ventral hernia through spigelian fascia at any point along its line. This is the transversus abdominis muscle, and this is the rectus abdominis muscle, and this is the midline. Here is the arcuate line. Here is the site of spigelian fascia, and this is the semilunar line. Here, if we come, we will find that this is the site of herniation. This is tendinous intersection with the rectus muscle. This is the site of hernia. Also, this is the site of hernia. Also, this is other site. So it may be superior or above, or it may be below. Above, spigelian hernia, which above constitute 10%. But below the umbilicus, it constitutes 90%. This is the site of ventral hernia, this is the site of umbilical hernia, and this is the site of spigelian hernia. So spigelian hernia is important because you are limited by the spigelian fascia and the arcuate line. So it presents as spigelian hernia, presents as soft reducible mass lateral to the rectus muscle and below the arcuate line with impulse on coughing. Strangulation is common in spigelian hernia. Common in females, as I told you, after 50 years of age. Differential diagnosis has to be put in your mind. Abdominal wall lipoma. Number 2, soft tissue sarcoma. And number 3, abdominal wall hematoma. Complications of open hernia are infection, growing pain, ischemic orchitis, injury of the valve, injury to the viscera, recurrence, and the hydrocele formation, as well as seroma, hematoma, and dysejaculation. Complications of using laparoscopic repair is subcutaneous emphysema, pneumothorax, vascular problems, neural problems, visceral problems, infection and the areas, and the recurrence, as well as conversion. These complications you have to take in mind, because subcutaneous emphysema can occur because you use the laparoscope and you inflate the abdomen. Air may come outside, and sometimes pneumothorax, and this is important because you have to deflate, because this may lead to subcutaneous emphysema within the abdomen. So ventral hernia is important as regards the four main times: incisional, ventral, incisional, umbilical, paraumbilical, epigastric, as well as esophageal hernia. This is important because you have to put in mind, sometimes you may get abdominal hernia in a lady with multiparous pregnancy, and then you say, oh, I can do repair. No, you can do what is known as abdominoplasty. What is abdominoplasty? You do transverse incision from one iliac point to the other, transverse. You cut the skin, subcutaneous tissue, and you go upwards, elevating the fat, because there is big fat, a big amount of fat, 4 to 5 kilos of fat. You will remove this fat up until the costal margin. Before you reach the costal margin, you will reach to the site of the hernia. The site of the hernia, you will do repair. After excision of this fat, you will do repair by opening the sac. If it is one sac, then you can do your repair by lysis of the intestine. If it is multiple, then you have to open the multiple loculi all over, because if you don't open them, internal strangulation may occur, and the recurrence with strangulation and bad prognosis for the patient. So if it is multiple loculi, then you have to open all the loculi and do lysis of the hernia, and then you introduce the intestine, and then you do your repair. As I said, by cutting the repair. If you do that, you can put a mesh and then excise all the fat till the costal margin. When you reach the costal margin, then you pull the skin, because you elevate the skin up. You pull the skin down so as to get it tight, and then you do subcutaneous suturing, and then suturing with the skin. Then you will get a new look for the lady. Her husband will be happy, and she also will get more appreciation or more happiness because of losing the pendulous, big, deformed abdomen, with sometimes skin erosion as a result of friction of the skin to the hernial sac and the hernial skin. And that's why we have to look for the skin before operation. If the skin is inflamed, then you can treat until the skin becomes normal and clean, because any infection or furunculosis within the skin is contraindication to surgical interference. Thank you.